Welcome back, Titans. Today we are talking about beta blocking agents, beta blockers, what they do, how we're going to use them, how they should be identified in the field, and what they're doing inside the patient's body when they're prescribed or we're giving them. So, what is a beta blocking agent? So, Nancy Caroline, Volume 1, 9th edition, describes a beta blocking agent as a drug that antagonizes the effects of epinephrine on beta adrenergic receptors. Now, going back to previous lessons, we know that beta 1 works on the heart, and beta 1 and 2, which is a non-selective, beta 2 being smooth muscle. Specifically, we're talking about the lungs. I like to remember it as beta 1 is one heart, and beta 2 is two lungs. So one heart, two lungs, beta 1, beta 2. Just a quick tip to remember that. So, what are the names of our beta blockers? When we first walk in, we were assessing our patients. We're doing a sample history. We're looking at their medication list. What am I looking for? So a lot, if you remember our previous video, a lot of the drugs that have a chemical, a generic, and a brand name, a lot of the generic names sound the same. So they're part of the same drug class or action. So the majority of the time, atenolol, labetalol, metoprolol, all those medications, if you see a beta or a drug that ends in the letters LOL, it's most likely a beta blocker. So that can key you into what your patients are taking. Obviously, we want to ask them what they're taking it for. So now that we've identified kind of what a beta blocker does, we are going to look at the selective and non-selective. So when we're taking beta blockers, it's usually for decreasing a heart rate, conduction velocity, myocardial contractility, all those fun things. But it's broken up into selective or non-selective. So if our goal is to lower the heart rate, maybe we're specifically looking at a beta 1. A good example of this is atenolol. Atenolol is a selective beta blocker that specifically works on beta 1 receptor sites as an antagonist. And that's going to help slow our heart rate down. We also have non-selective medications. Now, let's talk about propranolol. That is a non-selective beta blocker that works on beta 1 and beta 2 receptors, reducing and decreasing the heart rate and the force of contraction, causing some degree of bronchoconstriction. Non-selective beta blockers are contraindicated in patients with asthma and should be used in caution with patients with our COPD. So that's something good to remember. So that was pretty much the overview and the action. So what is our indication? So Nancy Caroline describes the indications as reducing myocardial ischemia, conversion to a sinus rhythm, to slow a ventricular rate, hypertrophic cardiomyopathy, non-cardiovascular conditions including anxiety, essential tremors, glaucoma, and then labetalol is recommended in emergency antihypertensive therapy for hemorrhagic and acute ischemia stroke. So, bunch of different things, bunch of different indications. Anytime we have an indication, we might have a contraindication. What are our contraindications? Obviously, any hypersensitivity, heart failure, cardiogenic shock, should not be taken by pregnant women or women suspected of being pregnant during breastfeeding. Relative contraindications include PR interval longer than 0.24, and so forth. Let's talk about adverse. So Nancy Caroline says that dizziness, weakness, fatigue, drowsiness, cold hands and feet, obviously bradycardia or AV conduction delays. Because remember why the majority of the time we take a beta blocker is to lower our heart rate. That could be an adverse effect. Does it have any interactions with other medications? So it's concurrent administration with IV calcium channel blockers can cause severe hypotension and bradycardia and or heart block. Check the book out. There's a bunch of different interactions that it can. So any special considerations that we should consider when we're delivering or we have a patient currently taking a beta blocker? So we're going to monitor the patient's blood pressure and heart rate, obviously, do an ECG, continuously monitoring our patients. Anytime we're giving a cardiac medication or the patient's taking cardiac medications, it's probably a good idea to reassess the patient frequently and keep them on an ECG and maybe even do a 12 lead. So we can also, ACE inhibitors have largely replaced use of beta blockers in the management of chronic hypertension. So that's another good thing to look for. So real quick video, hoped it helped. Keep an eye out for the lulls. beta blockers. We'll see you next time.